This is the lecture on mechanical ventilation. This is an abbreviated version of the lecture that was presented on Tuesday, 10th of September 2019 between 3 to 5 p.m. So these are the learning objectives that you should follow in terms of what you are expected to learn from this lecture. And some of the mandatory readings from the main textbook to help you understand the concept of non-invasive ventilation, mechanical ventilation, as well as your role as a physiotherapist to help someone wean off mechanical ventilation. So one of the few points to recall or remember is that one of the major factors determining whether breathing is producing enough gas exchange to keep someone alive is the ventilation the breathing is producing. And we will need to monitor that breathing through what we call ventilation or minute ventilation, which refers to the volume of air that is entering or leaving the lungs in a given amount of time. And for that, the formula for minute ventilation is the product of tidal volume and respiratory rate, sometimes referred to as F. Okay. And the units for minute ventilation will be liters per minute. So another few points to remember or recall is that the level of ventilation can be monitored by measuring the amount of carbon dioxide in the blood. So that's the reason why you studied ABGs. Okay, so the relationship between ventilation and carbon dioxide is inversely proportional. Okay, in other words, if you breathe more, you're likely to have a lower carbon dioxide in your body. But if you breathe less, in terms of hypoventilation, then you'll be retaining carbon dioxide in your body. Okay, when you breathe out, the process is passive, and therefore the pressure here becomes more positive because your ribs starts to go back to its resting state, the diaphragm starts to come back up to its dome shape, and therefore the pressure in here will be higher than the pressure here, and therefore a pressure gradient is created. Therefore, air moves out during exhalation. So if you review how you breathe now, when your diaphragm contracts or when your intercostals contract, lifting the ribs, creating the bucket handle movement, the negative pressure is being created within the thoracic cavity. And that thoracic cavity that is transmitted through the pleural space and then into the lungs, therefore creates a pressure that is lower than atmospheric. And because it's lower than atmospheric, we arbitrarily label that as negative. And therefore, this negative pressure being lower will allow air to move from the point of high pressure from outside to a point of low pressure inside. And then when you breathe out, which is passive, the diaphragm goes back to a resting state, your rib cage goes back to its resting state, and that pushes down or squeezes into the thoracic cavity, creating a more positive pressure than inside, than outside, and therefore air moves from inside the lungs to outside the lungs. Okay? So some points to remember is air always flows through a pressure gradient, i.e. a point of high pressure to a point of low pressure. Now because there's pressure change, so therefore air moves. And because air moves, therefore there's a volume change. So when you think of moments where you hold your breath at the end of your inhalation or you hold your breath at the end of exhalation, nothing happens, right? Because there's no airflow, because there's no pressure gradient being created. So if you think about it, at the end of an inhalation, if you hold your breath, or exhalation, if you hold your breath, there's no airflow, then therefore there's no volume change. So that's something for you to think about. In terms of mechanical ventilation, you need to understand the units that are used and some common terms. So number one, when we are talking about ventilation, the units of pressure is centimeters of water. When we are referring to units of pressure used for hemodynamics monitoring, we're referring to millimeters mercury. Okay, but of course you know that kilopascal is the SI unit, and also sometimes pressure is also referred to in atmosphere. So these are some of the converting factors. So just for your reference. So when we're talking about pressure, we are always in terms of ventilation, we are referencing that to atmospheric pressure at sea level. So we use the atmospheric pressure at sea level, which is 760 millimeters mercury or 1 atmosphere. as the baseline of 0. So we arbitrarily label that as 0. So anything above that, we call that positive. Anything below that, we call that negative. Okay, so just remember that the terms when we're really talking about negative is arbitrarily because there's no true negative on Earth. Okay. In terms of units of volume, we always use milliliters or liters. Okay, so that's quite straightforward. Other common terms which refers to lung characteristics, there are about two of them. Number one, compliance. This refers to how well something stretches or distends. And this is the opposite of elastance. Elastance refers to the ability of something that can return to its original shape. But compliance refers to how well something can stretch or distend. And that can be expressed in words in terms of change of volume corresponding with the change of pressure, and this is the expression. Okay? And the units for that, based on the expression above, is milliliters per centimeters water or liters per centimeters water. Okay, so just again for your reference, this is the general lung compliance for some patients who are intubated and mechanical ventilated. This is considered normal. For lung characteristics, another one would be airway resistance. So we're talking about the change in pressure that is divided by the flow through the airways. In other words, how much pressure is required to pass through a certain cylinder. So in this case, if we're referring to change of pressure over flow, please remember there's a dot over the V to represent flow, and flow is expressed in either liters or second. In this case, it's either expressed in liters per minute or liters per second, and in this case it's liters per second. Okay, and therefore the unit is centimeters water per liter per second. So normally for most patients, just generally intubated patients have approximately 6 centimeters water per liter per second or higher of airway resistance, mainly due to the presence of the endotracheal tube. So this is something that we've first introduced to you in PTY 2001, a concept called time constant, which essentially describe the characteristic of individual lung units or alveoli, and it refers to the compliance of the lung unit and also the resistance of the airway that is supplying that lung unit, and it is expressed as a product of compliance and resistance, and this is the expression mathematically. So what it means is time constant approximates the amount of time that's required to fill up a lung unit. So it can be 1 second, it can be 2 seconds. Some units may only start to fill in the 3rd second of the inhalation. Okay, so that's because of where they are situated, right? So that's the reason why when you recall, when we teach deep breathing exercises or thoracic expansion exercises, we always stress that the inspiratory time to take in a deep breath or to do the thoracic expansion exercise is a minimum of 3 seconds. So preferably 3 seconds or more to slowly take in the deep breath so that it allows different lung units with different time constants to open up. Okay, and that's when we really help with reversing atelectasis or preventing atelectasis. Okay, so please remember that. Okay. In terms of mechanical ventilation, there are essentially two types: negative pressure ventilation and positive pressure ventilation. So historically, mechanical ventilation was created as forms of negative pressure ventilation, and they were created as a result of the polio epidemic in the 20s of the last century. Okay, and it's not exactly very comfortable. So this is an example of the negative pressure ventilation called the iron lung. Okay, where a person is put inside this chamber, and then a negative pressure is being created through a bellow, and the negative pressure then help to pull up the chest wall, creating the negative pressure within the thorax, and therefore air moves in from outside in, and then this is reversed when the patient is supposed to exhale. So of course this is a very, very uncomfortable method, and thank goodness we don't use it. So this is the schematic for negative pressure ventilation. Just know that it doesn't happen anymore. Okay, it's not ideal. So modern times, all mechanical ventilation are positive pressure ventilation, and these are some of the models and makes of mechanical ventilation that you might see out there in Singapore's ICU. Okay. More model, and this is the model that you'll be seeing you have seen during the lab this week. Okay, and you'll have the chance to play around with. Then let's consider the manual resuscitator bag, which you are quite familiar with, right? Okay, and it is also a positive pressure ventilation when you apply the mask over the nose and mouth of the person, and then you are squeezing the bag with your hands. You're actually pushing in positive pressure into the person's lungs, and therefore creating the volume change, which you see as chest rise. So when we are referring to positive pressure ventilation, we are really referring to raising the pressure above atmospheric at the mouth or at the upper airway, and in this case, either through a manual resuscitator bag or mechanical ventilator, and then it's being pushed into the lungs. Okay, and that's how the inspiration happens. Of course, to the patient is somewhat passively, and during exhalation, everything is passive. The rib cage again goes back to its normal state, normal resting state. The diaphragm also wants to come back up into the dome shape, so therefore it pushes the air out. Okay, through another pressure gradient. So some of the mechanical ventilation terms that we also discussed during the lecture, and this will be we'll go through this in the next. So we're referring to baseline pressure in PPV, or positive pressure ventilation. We're almost always looking at pressure that is above zero, and that pressure is termed as positive end expiratory pressure, or PEEP, PEP. So this is an important thing, and the main function essentially, because it's above resting, it helps to distend the lungs, preventing the lungs from fully deflating, and therefore increases the FRC, or functional residual capacity. And there are two types of PEEP: extrinsic and intrinsic. So extrinsic PEEP are PEEP that is applied, okay, by the machine or by some other gadget. Intrinsic PEEP is PEEP that is created within, and usually this might happen with patients with COPD, patients with very weak airways, where the airways collapse prematurely, and therefore trapping air within the lungs, and that air or volume of air that is trapped within the lungs creates intrinsic PEEP or auto PEEP. Okay. The other pressure that you need to remember is peak pressure, okay, also known as peak inspiratory pressure, or PEEP. Okay, so differentiate this between PEEP and PEEP. So this is the pressure recorded at the end of each breath in terms of inhalation, and it's technically the sum of two pressures: the pressure that is required to push air through airway resistance, and the pressure that is needed to fill up the alveoli. So in a mathematical expression, then this is the sum of the pressure, or trans-airway pressure, and the sum of alveolar pressure, okay, at the end of inhalation. So this is the graph of airway, a pressure time curve that is with a baseline pressure of 10. Okay, so therefore this graph refers to someone who is on a PEP of plus 10 centimeters water pressure. Okay, and the patient is trying to take a breath, so there is a bit of triggering, and therefore you see the little dip down here because the person is like sucking, therefore triggering the machine to provide that breath, okay, by the machine. So at the end of the inhalation, this is the highest point, and therefore this is the peak inspiratory pressure. Okay. Now, if we ask the person to hold the breath, or we set the machine to don't allow the patient to breathe out, then this plateau may occur, and we call this the plateau pressure. The difference between the PIP and the plateau pressure is the trans-airway pressure, and this represents the pressure that is required to overcome airway resistance. Okay, so normally we may not see this little dip. It's just all the way to inhalation and an inhalation, passively immediately go down to exhalation. So this is the exhalation phase that is passive. Now, contrasting this part on the right, this is a spontaneous breath which we allow the patient to breathe spontaneously while on this baseline of plus 10 centimeters water pressure. So when you take a deep breath in, you create negative pressure, so therefore there's a dip, right? Suck in, and then you breathe out, and then there's positive pressure pushing the air up, okay? But the average pressure here is still 10. So for this spontaneous inhalation and exhalation, for this breath, this patient is said to be breathing on a CPAP of plus 10 centimeters water. So some points to remember. Again, air always flow down a pressure gradient from a point of high pressure to low pressure. Okay, and it's because of the change in pressure, therefore air flows, and because of the air flows, it results in change of lung volumes. Okay. You need to also remember this concept that all forms of ventilation increases intrapulmonary pressure. Okay, whether you are breathing now normally, or whether it's mechanical ventilation, or you're asking the patient to do deep breathing exercises with the incentive spirometry or spirometer, it's always about increasing transpulmonary pressure. Okay? The two concepts of lung characteristics, about compliance and airway resistance. High compliance means it's easier for the lungs to distend. Low compliance means the lung is getting stiffer, so therefore it's harder for the lungs to distend, and therefore a higher pressure is required to distend the lungs. For airway resistance, this is an important concept because presence of secretions or mucus plug can increase airway resistance and therefore can increase vocal breathing. Okay, this is the same concept as bronchoconstriction. Okay, where bronchoconstriction constricts the airway, therefore increasing airway resistance and therefore increases vocal breathing. We're now going to discuss the phases of delivering a mechanical breath. It's the same way that you actually would breathe. Okay, so your brain tells your diaphragm to breathe, so you initiate the breath, okay, and you take a deep breath in, so the machine pushes in the air. And then we set some limits in terms of the inspiration, either by time or by volume or by pressure, or both pressure and time, or volume and time. And then it just stops after the limits have been met. Okay, so when we say a breath is being cycled, okay, the cycling refers to the ending of the inspiration. So after the inspiration ends, exhalation occurs passively, and then the cycle begins again with the next breath. Okay. So for this slide, you need to remember essentially just two things: either machine breaths or mandatory breaths, or spontaneous breaths. These are the two main concepts I need you to remember. Just know that an assisted breath refers to when a patient can initiate breath, but the breath is actually assisted by the machine. So the machine delivers and stops the breath. So even for an assisted breath, the breath type is still classified as a mandatory breath. Okay? Then on the other side, we're talking about spontaneous breath, where essentially the patient really can spontaneously breathe. It's just that the breath is supported by the machine. Okay, not delivered, not controlled. So the patient can initiate the breath, can initiate the stopping of the breath. So therefore the inspiratory time is set by the person, him or herself. The volume or the depth of breathing is also controlled by the patient, him or herself, and not by the machine. Okay. So a very quick check for this question is this, and the answer for this is A, right? Okay, everything else is considered machine breaths. Only when you can know that the person or the patient starts or stops the breath, then you will know that that is a spontaneous breath. All other breaths, as long as there's a ventilator component to it, is always machine breaths or mandatory. Okay, so again, some points to remember. Patient can control the timing and size of the breath, spontaneous. Anything else, mandatory or machine breaths. Okay, so this is a very important distinction because you need to figure out, oh, if the patient is able to do spontaneous breathing on the mechanical ventilator, so maybe I can also get the patient to do deep breathing exercises, right? In order, because the patient can take a bigger size breath in order to help with his or her breathing. Okay, compared to a mandatory breath where you can ask the patient to take deep breaths, but the volume may not change at all. And therefore, you're not getting the benefit of a deep breath, okay, which refers to a larger than normal tidal volume. The objectives of mechanical ventilation, we've discussed also before, three main things: support and manipulate gas exchange, therefore helps to manage respiratory failure, especially type 2 respiratory failure, increasing lung volume, okay, so therefore it helps to prevent and reverse atelectasis. And at the same time, when you also increase FRC, you're also increasing or optimizing oxygenation and then decreasing vocal breathing. So if someone is so tired as a result of being so breathless, mechanical ventilation can help the person to rest. Some standard criteria for mechanical ventilation. Okay, as mentioned in the earlier slide, we're talking about type 2 respiratory failure. And of course, if someone is already not breathing, mechanical ventilation has to help. Okay, impending ventilatory failure literally means this person may go into acute ventilatory failure or type 2 respiratory failure, and therefore we should start to intervene by providing mechanical ventilation. So don't wait until the person goes into real acute failure before you intervene. So this is one consideration. The last part refers to refractory hypoxic respiratory failure or refractory type 1 respiratory failure. Now, refractory means when you are providing oxygen therapy, the patient is not responding. So the saturation is not coming up. For some reason, you give 100% oxygen through a non-rebreather mask, the oxygenation is not improving. So therefore, mechanical ventilation may be needed, okay, in order to provide the pressure to open up some of the alveoli and therefore increasing the gaseous exchange surface area for oxygen to get through. Some common modes for mechanical ventilation, you have already covered most of them in the lab this week. Okay, CPAP, spontaneous mode. Okay, just know that there is only one pressure. Okay, so in this mode, you are actually breathing normally. Okay, there's no additional pressure being pushed in during inhalation. There's no additional pressure being decreased or removed during exhalation. It's just one constant pressure. That's why it's called continuous positive airway pressure. Okay, and this can be applied through an artificial airway or a mask, and most of the time it is through a mask. Okay. For this point, just know that for adults, it is hardly used as a mode of ventilation anymore, but it's more commonly used in neonatal and pediatric ICU. Okay, and for adults, it's generally used as a non-invasive ventilation, more commonly as nocturnal CPAP that you wear at night to help with patients who has obstructive sleep apnea. So when you look at it, this is again normal breathing, right? You breathe out, you breathe in. You breathe out, you breathe in. You breathe out, you breathe in, and then we add 10 centimeters water of pressure, and then now your baseline pressure is went from 0 to 10, and you continue to breathe out, breathe in, breathe out, breathe in. Okay, so the sensation is almost like you're not allowed to fully empty your lungs before your breath. So you always feel that your lungs is slightly inflated. Again, that's what CPAP does, and therefore it helps with oxygenation, okay, by means of increasing FRC. Okay. Pressure support ventilation, also a spontaneous breathing mode. So in this case, we have two pressures, right? So just know that it's a spontaneous breathing mode, which means patient initiates all breath, determines the respiratory rate, inspiratory time, and tighter volume. Okay? And it can also be administered through an artificial airway or a mask gas non-invasive ventilation. So in this case, we are referring to two pressures. Okay, so please disregard this CPAP here. Okay, we are talking about two pressures: the baseline pressure, which is the PEEP, okay, positive end expiratory pressure, and then the pressure support, okay, which is the pressure that is supporting the inhalation. So in this case, when the patient takes a deep breath in, the machine supports the breath with that 10 centimeter water pressure, and back down, exhalation, inhalation, exhalation, inhalation, exhalation. Okay, and the S's here refers to spontaneous breaths. Okay, so this is quite straightforward. So when pressure support was first introduced, it was meant to overcome the vocal breathing that is imposed through the ventilator valve, the circuit, and the ETT, especially the ETT, because the ETT is as if you are breathing through a drinking straw, right? And therefore, there's a lot of there's considerable levels of airway resistance. So pressure support was meant to help overcome that airway resistance. Okay, but it can also be used to provide ventilatory support. So most of the time, when you see patients on spontaneous breathing mode, it's almost always pressure support ventilation. We've already discussed PEP, okay, the positive pressure that is left during expiration or the baseline, and these are the three functions that we've discussed, why PEP is important. Okay, so again, another graphic in terms of baseline of 0 and then a PEP of 5 is added in this graphic. Okay. Then we will talk about two quite commonly used mandatory ventilation mode. Okay, VCV, volume controlled ventilation, or PCV, pressure controlled ventilation. Now sometimes they are also called pressure controlled assist control mode or pressure controlled assist control mode. Okay, so sometimes, at least for the ventilator that we have in SIT, you will see that it's referred to as VC AC or PC AC. Okay, so for these modes, a minimum rate is being set, and then even though a rate is set, the patient can breathe more than the set rate. So therefore, the patient can trigger the breath. However, even when the patient is triggering the breath, every breath on these modes are all mandatory breaths or machine breaths. Okay. So if you look at PC, AC or pressure control ventilation, we are really talking about the breath being pressure controlled. So there's a pressure limit set called the inspiratory pressure. Okay, so this is used to minimize barotrauma. So therefore, the breath is delivered with a set pressure, so it will not exceed the set pressure, and therefore it's somewhat safer for the lungs. And we will set the pressure at which the lungs will be inflated, and then the time that this pressure it will go to. So if it's 1 second, the pressure will be sustained there for that 1 second. Okay? So graphically, this is what it means. This is the set inspiratory pressure, that's what IP means, and then that's the pressure above the PEP. Okay? The C here refers to controlled breath, so when it's time to deliver the breath, it's breathe in with the IP sustained for say 1 second, if the I time is set at 1 second, and then after the 1 second is done, the machine cycles off, and then exhalation occur, and then that cycle repeats itself. Okay, so you look at that is the intervals between each breath. In this case, is quite uniform. It's because all these breaths are controlled breaths. Okay, so this is an example of a person who is probably anesthetized or paralyzed or sedated and is fully dependent on the machine to breathe for them. Okay, volume controlled ventilation or VCAC, in this case, the breath is delivered with a preset volume. So we set the volume. In this case, we can either set in an I time or a flow rate. So most machines now give you an option to also set the inspiratory time together with the flow rate that is used to deliver the tidal volume. Okay, so contrast this with pressure control ventilation, where we set a pressure. For volume control ventilation, we set a volume. So comparing the two modes, volume mode, pressure mode, and we are looking at what is the constant or fixed and what is the variable. So for the pressure mode, obviously the pressure is fixed and therefore the volume is variable. Okay, so if the lungs are stiff, then for the same fixed pressure, okay, there will be a return of lower volume. Likewise, if there's a higher airway resistance for the same fixed pressure, there's a lower volume. Okay. Contrast this with volume controlled ventilation, where the volume is constant, okay, then the pressure is variable. So this is what we'll be monitoring, right? The variable part. Under volume controlled ventilation, if the lungs are stiff, in other words, if the lungs have low compliance, then it will register a higher pressure for the same amount of volume. Okay, so the PIP will be much higher. So same thing for high airway resistance. For the same amount of volume, it also will register a higher amount of pressure because it takes more pressure to deliver this volume. Okay, so try to understand this variable so that it helps you to understand how each modes work. Okay, I think probably this is one of the final ones in terms of SIMV. This is synchronized intermittent mandatory ventilation. So we are literally now combining the two types of breathing: the controlled breathing, controlled ventilation with a spontaneous breathing mode. So it's either a volume controlled ventilation (VCAC) with spontaneous breathing. Usually, in this case, is pressure support ventilation, or PCAC, pressure control assist control with pressure support ventilation. Okay, so mandatory breaths are set in between the patient allowed to breathe spontaneously. Okay, and I said before, the spontaneous breaths are pressure supported. Okay, why is it called synchronized? Because when it's time to deliver the mandatory breath, the machine can detect the patient's inspiratory effort and therefore will synchronize with the patient to deliver the machine breaths. So it will not be difficult for the waking patient. Okay. So some of the example graphic. So this is the C refers to control breath. A refers to assist breath. Why is it assisted? It refers to the patient triggering the breath. So there's a little dip down here that refers to the assistance. Okay, so triggering, then the machine provides that machine breath to assist the breath. Then you will see the S here that refers to spontaneous breathing, and this is a square wave. As I mentioned also before, that every pressure type volume ventilation is almost always a square wave. So there's a dip here that refers to the patient triggering the breath, and therefore and then some support is being given by pressure. Okay, so in this graphic, this is a volume control breath. Okay, that looks like a shark's fin or a triangular type of shape. Volume control breath, and then spontaneous breathing, square wave, pressure supported breath. These are some of the settings that the clinician will put in. Don't worry, you're not the one going to do it. You're not, physiotherapists won't deal with ventilatory settings. It's always the respiratory therapist or the clinician or the trainers. So some points to remember. So in terms of mechanical ventilator, can be considered as controlled or assisted. Controlled meaning everything is done by the machine. Assisted means the patient can interact in some way with the ventilator, and most of the time it's about triggering the machine and therefore the breath is being delivered. Okay. So when we look at this graph, we are referring to the spectrum of patient participation. So on the left, we're talking about more controlled ventilation, where the patient requires more help from the mechanical ventilation. And then moving towards the right, the patient can breathe more on their own and therefore eventually become independent and be able to breathe on his or her own. So looking at the different modes that the patient is at, you can then therefore determine how the rehabilitation journey or the treatment plan or therapy plan for the patient in terms of how you would like the patient to be more active, in other words. So that's that for mechanical ventilation. So we're going to talk about things that we might need to monitor when the patient is on mechanical ventilation. So as we discussed in the earlier part of the lecture, we did say about monitoring the level of ventilation by measuring the amount of carbon dioxide in the blood. And that, of course, can be done by taking arterial blood gas, okay, to monitor the amount of carbon dioxide in the bloodstream. Now, because that can be very expensive, time consuming, and then ABGs only tell you about the respiratory system or the amount of the level of ventilation at that snapshot of time. So therefore, something is being created to monitor carbon dioxide in the breath on a breath by breath basis, right? So that's called capnography. Okay, so again, we recall that the amount of the relationship between level of carbon dioxide in your blood and the level of ventilation is inversely proportional. So therefore, you hyperventilate, your CO2 goes down. You hypoventilate, your CO2 will go up. Okay, so please remember that. So carbon dioxide monitoring is capnography, is a sensor that detects the carbon dioxide, okay, at the end of each tidal volume breath. So that's what this end tidal means. Each at the end of each exhalation, that's the value that we're looking at. So this is used because we know that it correlates very closely with PaCO2, that is the carbon dioxide levels in your bloodstream, and therefore we're talking about it is somewhat in the range of 1 to 5 millimeters mercury less than PaCO2 levels. So we should expect normal values to be between 30 to 45. Okay. So if you look at this graphic, the orange part, okay, in this case, okay, don't get confused. In this case, it refers to exhalation, okay, because we are looking at the y-axis, which refers to the amount of carbon dioxide in the breath over time. Okay, so therefore, during exhalation, your CO2 will be higher, right? And then during inhalation, in the breath, there will be less CO2. Make sense? Okay. So how does this, so we are looking at this point. So this is the point where the measurement is being taken. Okay. The end tidal CO2, the carbon dioxide level in the breath at the end of exhalation. Okay. So this then tells us, by looking at this carbon dioxide monitoring graph or this capnography, that we can look at whether the patient is breathing out efficiently. Okay, in this case, this particular graph, the second graph, refers to someone that might be rebreathing carbon dioxide because the patient is not given enough time to breathe out. Therefore, the IE ratio is not optimized. Okay. The second example here is if we're referring to hypoventilation, where the patient is not breathing efficiently, right? There's decreased minute ventilation, and therefore the carbon dioxide level starts to rise. Okay. And conversely, so think about if someone is hyperventilating, okay, then how would you expect the graph to look like? Okay, something for you to think about. We're going to move on from invasive mechanical ventilation to non-invasive ventilation. And this is ventilation that is administered without the insertion of a tube or an artificial airway, and definitely just through a mask. So it's very similar to how you've done the back mask ventilation. So instead of you manually giving that breath, the breath is given by a machine, and that's non-invasive ventilation. And the mask can be a full face mask that covers both the nose and the mouth, or a nasal mask that only covers the nose. So these are some examples of non-invasive ventilation mask. Okay, so this is a nasal mask. Okay, and these are the headgear and the head straps. Nasal pillow, so two little prongs that goes into the nostrils. Okay, a full face mask, okay, that covers the mouth and the nose, And then this is a combination of nasal pillows, so a little prongs will go into the nose, and then this covers the mouth. Okay, and then there are also other designs. Of course, the one down here is no longer in use. This is a very, very old model. Okay, so just know that things people have to endure in the past in order to survive. So if you look at this graphic, this is what it means. So this is just an example of how NIV is being delivered, and in this case the interface is a nasal mask. So the machine delivers the positive pressure through the mask into the nose, down into the lungs, and therefore inhalation occurs. Of course, you also help, you take some breath to help with the machine, right? So air moves in. As you exhale, again, passive process, everything get pushed out, and your exhaled air is being breathed out or vented out through a little vent in the mask. That's how it works. So some indication for non-invasive ventilation, and most of the time is because, number one, you may not want to intubate someone, so therefore you want to use non-invasive ventilation to help the patient tide through that period of difficulty in breathing. Okay, so all these are some of the indications for non-invasive ventilation. Okay, with a particular note for this last point, do not intubate status. So sometimes there are patients who allow themselves to be resuscitated, but they do not want to be intubated. In other words, they do not want to be on a breathing machine. So this is the kind of situation where if the patient has difficulty breathing, but we cannot put in an artificial airway or an ETT to help the patient to breathe, then therefore non-invasive ventilation might be suitable. Okay, some relative contraindication for NIV, you don't have to remember this. This is just for for information's sake. And the two common modes for NIV is CPAP and pressure support. Okay, you already know CPAP refers to one constant pressure. Okay, and PSV has two pressures. So in this case for NIV, sometimes the terminology used to describe PSV is BiPAP. Okay, or bi-level positive airway pressure. Two levels of positive airway pressure. Okay. You are familiar with PSV, so you know that there's a pressure support to help with inhalation, and there's a baseline pressure called a PEEP that is there at the end of exhalation. So some machines may term this as IPAP, inspiratory positive airway pressure, for the pressure support, and use EPAP, expiratory positive airway pressure, to refer to the PEP. Okay, additional things that can be added will be oxygen, and sometimes some machines can provide a backup rate, and therefore if the patient really goes apneic, it can provide backup ventilation. So you've understand some of the terms and physiology about mechanical ventilation, so you need to understand a little bit about the effects of mechanical ventilation on the different systems of the body. And of course, as a physiotherapist managing a patient in the ICU, you really need to know about the effects of mechanical ventilation on the lungs, okay, and so some of the side effects that it can bring about, and also some of the side effects that mechanical ventilation has on the heart in terms of hemodynamic stability. Okay. So positive pressure and mechanical ventilation on the lungs, just need to know that the ventilation gradient is reversed, because with mechanical ventilation, your diaphragm don't work as actively compared to when you are breathing normally. Okay, and so the diaphragm remain domed shape, right, pushing up against the lungs, and therefore it's a little bit harder now to ventilate the region of the lungs that are nearer the diaphragm, right? So when air is being then pushed into the airway, the air, like all fluids, will always take the least path of least resistance. So therefore, air will always go to the regions that are more open, and therefore we're talking about the upper lung region. Okay. The lower region, as I said, is of the resistance from the resting diaphragm, which is domed up against the lungs. It is also because by virtue of gravity, the lower region blood goes down to the lower region, therefore it also makes it a little bit harder to distend. And just remember, in terms of ventilation, mechanical ventilation on the lungs, air will move up to the upper region more first before they move into the lower region, because the upper region is easier to open. Okay, so if you remember this from PTY 2001, this graphic on the left, okay, refers to spontaneous breathing, okay, the VQ distribution. Okay, so your diaphragm actively descend, flatten, and therefore creating the negative pressure within here, and is then therefore air goes in here very, very easily. So therefore more ventilation down here, more ventilation down here, okay, in terms for spontaneous breathing patient. When you look at the one on the right, this is a patient with is on mechanical ventilation. Okay, the diaphragm is not working as actively and therefore remain more dome shaped. Okay, so if you look at all this little bubble, they are quite small, and you have the diaphragm up here, and when air is being pushed in, it is harder to go into these places. So therefore, air goes through the parts of least resistance, will go to the upper regions first. So you probably get more ventilation in the upper region for someone who is on mechanical ventilation. Likewise, for someone who is lying on the side, okay, compressed, okay, by the weight on top, compressed by the abdominal pressure, and also by perfusion. So these lung units are hard to ventilate, right? Harder to get through compared to the lung units up here. Okay, so that's what this ventilation gradient means. Okay, but knowing this, okay, doesn't change how you manage an adult patient, okay, because the principle of good lung down, bad lung up still applies, regardless whether the patient is intubated or not, okay, in terms of treatment. Whether you are positioning for VQ matching or whether you are positioning for gravity-assisted drainage for airway clearance, the principle of good lung down, bad lung up still applies. Okay. So some of the side effects of mechanical ventilation on the lungs would include all this, okay, ventilator-associated pneumonia, lung infection that happens after intubation, and it can happen quite frequently. So that's the reason why when we do airway suctioning for patients like this, the technique needs to be sterile and clean, okay, so that we are not introducing pathogens to the patient, and we don't want the patient to get pneumonia while being hospitalized. Okay. VILI refers to ventilator-induced lung injury. So this is lung injury that makes the lungs stiffer as a result of repeated stretching and de-stretching of the lung units as a result of pressure. So you stretch the lungs too much, and then you de-stretch. It causes damage to the elastin and the soft tissues of the lungs, and therefore it triggers an inflammatory process that then therefore goes into something that will resemble ARDS, or acute respiratory distress syndrome. We will discuss this ARDS in the lecture in week 4. Okay. Then two other trauma related to high pressures, trauma related to high volume. So for barrel trauma like pneumothorax, and volume trauma is highly related to VILI. Okay, so it's just all about stretching or overstretching the lung units. Okay. Then the airway related ones are damage to the nasal or pharyngeal airways as a result of the intubation, the presence of the endotracheal tube, and also the airway suctioning process. Okay. So every clinician in the healthcare team, in the ICU team, is responsible to make sure there is no harm done while managing the patient on MV. So if you think, your understanding of physiology, your understanding of mechanical ventilation, your understanding of medicine, that something is not quite right with the patient, and therefore, and the team hasn't picked it up. Maybe it's your time to advocate for the patient and point out that maybe they would like to consider this or consider that the pressure is too high. Maybe we need to switch the mechanical ventilation from the volume mode to a pressure mode in order to protect the lungs. Okay, most of the time, of course, the very, very experienced clinicians would already know how to do that. But sometimes, when we get busy and everyone just think, things are fine, but you are the only one who's with the patient for half an hour during the physiotherapy session, and you notice something is not quite right, and it's your responsibility to report and say something. Okay. I think this should be one of the final ones. We're talking about weaning from mechanical ventilation. So when we're talking about weaning, means discontinuation from mechanical ventilation, and most of the time is also to assess whether the patient is ready for extubation. Is the patient ready to have the artificial airway removed and therefore to be able to breathe spontaneously? Okay, so the most important thing, is that the causes and reasons that caused the mechanical ventilation to be implemented should be assessed, and it should be reversed, right? So the pathology that caused the need to intubate and the need for mechanical ventilation should be reversed. Okay. Then we have to determine whether the patient can oxygenate and breathe efficiently. So we use oxygen index of PF ratio, which you've learned in the second lecture on respiratory failure by Prof. Meredith. The patient does not require high PEEP levels or does not require high oxygenation level. So this will help us to determine when we remove the mechanical ventilation and remove the breathing tube, whether the patient can breathe on his or her own. Okay? And your role is, in terms of mechanical ventilation weaning, is to assess the patient's rehab potential. So you do your full assessment, assessing the respiratory system, assessing the neuromuscular skeletal system, assessing mobility, assessing transfer, to help with the patient's recovery. Okay, so of course, as I said, respiratory system, secretion clearance, okay, mobilization to induce demand ventilation, and also to help with neuromuscular skeletal rehabilitation. We may also help with identifying readiness for extubation. So the team might ask you, how is the patient doing? Are there still a lot of secretions? Are there less secretions? What's the color of the secretion? Do you think the patient needs to be intubated more because there's more secretions and they need to be managed? Or does the patient, so they may ask you, do you think the patient can be extubated? So you may have to give your opinion with regards to that. Okay, of course, that's not expected of an entry-level physiotherapist. We are really talking about someone who is covering the ICU on a regular basis. Okay, this kind of team participation and team discussion. So at some places, we may be the one doing the extubation, physiotherapist. So in UK and Australia, the physiotherapist might be the one doing it. The physiotherapist may also be the one initiating non-invasive ventilation after the extubation to help the patient a little bit when the tube is being removed. Okay, the physiotherapists are also actively involved in tracheostomy team. So in the tracheostomy care teams in the hospital, so we help with tracheostomy care and also tracheostomy weaning. Okay. And at the same time, you also help with identifying patients with difficulty weaning. So patients with lung issue, COPD, for example. So as I said, as part of the ICU team, you help to provide the opinion and advice as to whether the team should proceed to do what they need to do. Okay, so that's that. I actually wanted to record this in half an hour, but it turns out to be about 55 minutes. So it is a bit lengthy, so I apologize and appreciate your patience and your interest if you've watched this entire video lecture. If you have any questions, please post them in the discussion forum on Excite and we will address them, and so that everyone who views or reads the forum can benefit from it too. Thank you very much.